There's Great. Hi, welcome to this webinar. SIBO, everything you need to know about the number one. Check again. Okay, just getting over a few technical difficulties here, and we'll be starting any minute now. Okay, all right. Well, I've got the go-ahead that the microphone is working. A few technical difficulties with this rainstorm and windstorm here in BC. We had the internet cut out and we just got it back. So glad that everyone can join me here today for this this webinar, SIBO, everything you need to know about the number one cause of IBS. My name's Tomah Phillips, and I think it should be a pretty interesting webinar. So let's get into it. So an overview of what we'll be covering today. So first we'll talk about a bit of an introduction and just what actually is SIBO. So we'll try and define what SIBO is, as well as what are some of the underlying causes that lead to the development of SIBO, because that can be really important when we talk about treatment and as well as preventing recurrence of SIBO. What are the clinical manifestations? So the signs and symptoms that might present in your clinic, the underlying pathophysiology of how those signs and symptoms arise. Then we'll talk about diagnosis. So what are the best options for diagnosing SIBO, as well as interpreting the test. So this can be a little bit tricky. So we'll talk about that. And then treatment options. We'll discuss pharmaceutical options, herbal, as well as dietary considerations. And lastly, we'll talk about some strategies to prevent relapse, because as we'll see, relapse can be very high in SIBO, so things that you can do to prevent that from occurring. And that should take us about an hour or so to get through, and that would conclude our CE portion of the webinar. And then following this, I'll go through my own personal protocol that I use clinically for SIBO, as well as some product recommendations that I use. So a little bit about myself. I graduated from the Boucher Institute of Naturopathic Medicine, where I'm now an instructor of Biomedical Sciences, and I also teach physiology and pathology at the Canadian School of Natural Nutrition in Vancouver, and I see patients out of Evoke Integrative Medicine in downtown Vancouver, and I work as part of the medical advisory panel for Vita Professional Therapeutics. So as probably many of you, keep myself very busy. Before we get started, just a couple of housekeeping things. So this is what you should be seeing on your screen. This is the Adobe interface for the webinar. So what you'll see in the bottom right-hand corner is a chat section where you can chat with the group, or you can select on the right corner there individual members to chat with. And then there's a box that has Q&A. So if you have any questions that come up during the webinar, you can write those into the Q&A section, and I'll be saving questions for the end of the webinar where I'll go through them. So feel free to type them in if they come up as we go along. And then you'll also see a little signal with a person with their hand raised up, and you can select different things here like speed up, slow down, laughter, and applause, which I happily accept, but really these are all just things that will pop up in my view, so probably no need to really use those. All right, so let's get started. So what is SIBO? So as the name implies, it's an overgrowth of bacteria in the small intestine. So bacteria that should not normally be residing there in large quantities, for whatever reason, overgrow. This bacteria will then lead to problems with the normal digestion and absorption of our nutrients, as well as these bacteria will produce, by fermenting our carbohydrates through the diet, will be producing gases that will then lead to many of the symptoms that we see that are common in IBS, such as gas, bloating, diarrhea, constipation, what have you. And as we'll see, there are a number of different causes that can lead to the development of SIBO, and SIBO is really, it's associated with a variety of different conditions as well. So as far as actually defining SIBO, this is actually harder than it seems like it should be. So there's not really a single accepted definition for the diagnosis of SIBO. So previously, gold standard was based on the presence of greater than per milliliter of proximal small intestine aspiration. So this is what used to be a standard for a diagnosis of SIBO. However, there was some controversy around this diagnosis, and some other research estimates that normal people should rarely exceed around 1,000 bacteria or colony forming units per milliliter in the small intestine. So not really a single accepted definition for what SIBO is. And to add to that, in most research and clinical practice nowadays, the endoscopy and aspiration isn't really used anymore, and instead diagnosis is made indirectly using a hydrogen methane breath test. And even within that, what constitutes a positive diagnosis of SIBO varies from lab to lab and practitioner to practitioner. So really, when we talk about SIBO, there can be a wide variety and it can be somewhat open to interpretation. So this can make it a little bit difficulty when you're wading through all the research that's out there. Um, Before we get into some of the pathophysiology and signs and symptoms of SIBO, it can be helpful just to do a quick review of our anatomy of the digestive system. So we know that the small intestine normally has low levels, very few bacteria, and it's going to be specialized for digestion and absorption of most of our nutrients, whereas the large intestine is filled with bacteria. We know that the bacteria there help ferment some of the foods, and that's completely normal. So in order to maintain the low counts of bacteria in the small intestine, we have a couple mechanisms at play. Above the small intestine, we have the highly acidic environment of the stomach, and this prevents bacterial overgrowth that could potentially make its way down into the small intestine. Below the SI, we have the ileocecal valve that's separating the small intestine from the large intestine. So if you have any dysfunction there, it could be possible to have some backtracking of bacteria from the colon into the small intestine. And then a third thing that's not talked about as much, and maybe it might be a relatively new topic for some people, is something called the migrating motor complex. And so what this is basically a periodic contraction that begins in the stomach and makes its way all the way down through the small intestine, and basically cleanses out or sweeps through the small intestine, clearing out any bacteria, dead cells, other debris, and prevents overgrowth of bacteria from occurring in the small intestine. So this is going to be really important when we consider both the underlying causes of SIBO as well as when we're talking about treatment and prevention. So we'll talk more about this migrating motor complex to come. And the last note is that SIBO is characterized by high levels of normal bacteria. So the bacteria themselves are not pathogenic like you might see with dysbiosis of the large intestine, but they're normal bacteria, commensal bacteria, but they just don't normally reside in such high numbers in the small intestine. So that's where the problem really arises from. So irritable bowel syndrome, IBS, I'm sure it's something we've all experienced in our practices. We've seen patients come in with IBS, and for a long time, patients who had these non-specific symptoms of abdominal pain, gas, bloating, diarrhea, constipation, often if they went to see their medical doctor, if there was no organic cause identified, which often is the case, they would get this label of IBS, which really we know is more of a constellation of symptoms rather than explaining the underlying disease that's causing them. And so having said that, as naturopathic doctors, we have lots of tools in the toolkit that can help with these non-specific digestive symptoms. So someone comes in with some of these symptoms, we may consider food allergy or food sensitivity testing or elimination diet, digestive support such as digestive enzymes, probiotics, stress reduction, acupuncture could be on this list. Many things that can help a lot of people with these digestive symptoms, and lots of patients will get better just doing these basics. However, what about those patients who don't improve when you've done the basics? So that's really where SIBO comes in as a consideration. So that brings us to our next point. So why should you even care about SIBO? Obviously, you care enough in that you're attending this webinar to learn a little bit more about it, but there are plenty of reasons to care about SIBO, or at least be aware of it as a potential diagnosis for your patients. So we know that gastrointestinal complaints are probably the most common reason for doctors' visits in North America. That's both medical doctors and naturopathic doctors. And out of these digestive disorders, IBS is probably the most common one. So it's estimated that in Canada there's about 5 million cases of IBS, with about 120,000 new cases of IBS annually. So it's a significant portion of the population that suffers from these issues, and there's a lot that we can do to help with it. So we know that 5 million people in Canada suffer from IBS, and then some research studies estimate that SIBO is actually the underlying cause in up to 84% of IBS cases. So if you did the math there, that would be 4.2 million Canadians that are actually suffering from SIBO, according to these statistics. So if you looked at some other research, some estimates are a little bit lower, indicating SIBO in about 30% of IBS cases. It's likely somewhere in between that, probably about 50 to 75% of IBS cases have an underlying root cause of SIBO. And another important aspect is that SIBO can be related to many other common conditions that we see. So for example, celiac disease, it's estimated that SIBO can be contributing to the dysfunction there in about 50% of cases. So if you're able to treat and eradicate SIBO, you can see a greater improvement in patient symptoms. And then lastly, elderly patients may be more susceptible to the development of SIBO. And we know that our elderly populations are continuing to grow in Canada, so this can be a significant portion of patient populations. And the reason that they're more susceptible, there could be a number of reasons. Some of them might be lower stomach acid levels with age, being on many different medications that may predispose to SIBO, or other factors may be at play there. So with SIBO, it's not really enough to just treat SIBO itself, that is eradicating the bacterial overgrowth. But as clinicians, we want to know, why is SIBO arising in the first place? Our naturopathic principle of tolle causum, identifying and treating the cause, is going to be really important for the treatment as well as the prevention of relapse for SIBO. So bacterial overgrowth in the small intestine can occur anytime that we have stasis, which gives the bacteria an opportunity to grow and proliferate locally in the small intestine. So stasis could be due to something like a bowel surgery, could be due to a neuropathy, such as you might see with diabetes, some autoimmune diseases like scleroderma, if someone has diverticulitis or diverticulosis, any sort of intestinal obstruction due to strictures, adhesions, tumors, cancers, anything that's causing this stasis can predispose to the development of SIBO, as well as certain medications can also be an underlying cause in the development of SIBO, such as proton pump inhibitors, which we know are one of the most widely prescribed medications, but by blocking that stomach acid, we no longer have that upper level of protection from overgrowth. So that can be one thing to consider as well. And then a really important underlying cause is dysfunction of that migrating motor complex. So the migrating motor complex, as we mentioned, that in between meals or during fasting periods, so overnight or in between meals, we have this wave of contraction that starts in the stomach, makes its way all the way down through the small intestine, and it basically acts as a housekeeper or a cleaning wave to clear out bacteria that are there. However, we can get dysfunction of this migrating motor complex. One reason that can arise is due to gastroenteritis, which we'll talk about. Again, diabetic neuropathy can affect it, hypothyroidism, any sort of nerve damage, medications such as opiates or narcotics, surgeries, and stress. So there are a number of things that can alter this migrating motor complex and make the overgrowth of bacteria more likely to occur. this is actually a really interesting mechanism. It's something called post-infectious IBS. So this is well documented in the literature that in about 7 to 30% of people, when they have a bout of gastroenteritis or gastrointestinal infection, they'll go on to develop a condition called post-infectious IBS. So it's basically IBS following gastroenteritis, and usually it's chronic digestive symptoms. However, we now know that most of this post-infectious IBS could actually be considered post-infectious SIBO. So we even know the mechanisms of how this can arise. And some researchers would actually estimate this level to be even higher, that this gastroenteritis is one of the more common causes of someone eventually developing SIBO. So what can happen is that bacteria such as the Campylobacter bacteria that cause gastroenteritis, they secrete toxins called cytolethal distending toxins, or CDTs, and these can actually go on to impair muscle and nerve connections and inactivate or cause dysfunction of that migrating motor complex. So without getting into too much detail, one component of the cytolethal distending toxins, the CDT or CDTB, which seems to be the worst one, acts through sort of an autoimmune mechanism where it forms antibodies to vinculin, which is a cytoskeletal protein that we have. And then our immune system, trying to attack this, will damage small intestinal nerves as well as pacemaker cells that control the migrating motor complex. So this is the underlying mechanism of how gastroenteritis can lead to the development of SIBO. So a number of organisms have been identified that can release these cytolethal distending toxins, and these include the Campylobacter, as mentioned, but as well Salmonella, Shigella, E. coli, Giardia, and even certain viruses have been shown to do this. And so what occurs is, if you follow this figure, the bacteria release the CDTB, which forms anti-vinculin antibodies, and then these will cause damage to cells called the interstitial cells of Cajal, which basically are pacemaker cells of the migrating motor complex. So if we have a decreased number or decreased activity of these interstitial cells of Cajal, that can lead to dysfunction and inefficient function of the migrating motor complex, which can then predispose to bacterial overgrowth. And in this case, it says post-infectious IBS, but you could change that to post-infectious SIBO in many cases as well. Just going to go back here for a second. It's sort of interesting to note that there's a new test that's been developed that's coming into play that can actually measure for anti-CDTB antibodies as well as anti-vinculin antibodies. So this could be potentially a helpful test for patients who have this post-infectious IBS or post-infectious SIBO, because if they have these antibodies present, it's likely to be continuing to affect their migrating motor complex and prevent treatment from being effective. So what is the pathophysiology of SIBO? So we've talked a little bit about it, but this graph really sums up nicely about what's happening, how the symptoms are arising with SIBO. So due to one of those underlying causes we talked about, for example, gastroenteritis, we develop some bacterial overgrowth in the small intestine. Then the bacterial actions can produce inflammatory cytokines that can produce an inflammatory reaction, cause damage to the brush border, as well as cause deconjugation of bile, and that can disrupt our ability to absorb fats. So you may see fat malabsorption as well as deficiency of fat-soluble vitamins, namely vitamins A, D, E, and K. And this damage to the brush border can also damage the disaccharidase enzymes that digest our disaccharides, and it can lead to increased intestinal permeability. So this intestinal hyperpermeability, what we often call leaky gut, this can then result in all of the systemic symptoms that could be a part of SIBO. So could be skin symptoms, headaches, fatigue, joint pains, what have you. all of these systemic symptoms can arise in SIBO due to this increased intestinal permeability. And then now, because we've had damage to the brush border enzymes and disaccharidases, we're not able to effectively break down and absorb carbohydrates. So now those carbohydrates will become food for the bacteria that have overgrown there. So the bacteria will ferment those carbohydrates, producing mostly hydrogen and methane gases. And this gas production is what leads to many of the IBS symptoms that we see. So namely the bloating, abdominal pain and cramping, constipation, diarrhea are mostly the result of this increased production of hydrogen and methane gases. And then because the bacteria have been feeding on our carbohydrates, it continues this bacterial overgrowth. So we end up in this vicious cycle where we're getting continued overgrowth and continued symptoms of SIBO. So this is really the underlying pathophysiology that we see. The clinical manifestations or symptoms that you're likely to see with SIBO. So the non-specific intestinal symptoms or IBS type of symptoms are mostly due to the increased gas production. So distension, bloating, flatulence, eructation, abdominal pain or discomfort, diarrhea, constipation. All of these things can be manifestations from that increased gas production. And they estimate with SIBO that normal bacteria, if we drank, a normal person drank about 1 ounce of milk, they'd produce around 50 milliliters of gas. Whereas in someone with small intestinal bacterial overgrowth, that same 1 ounce of milk would produce around 5,000 milliliters or 5,000 cc's of gas. So you can see it's quite significant, the gas production that can occur with SIBO. Malabsorption, as mentioned, due to that bile deconjugation and increased intestinal permeability. This tends to occur more so in severe or chronic cases, but you can definitely see deficiency of those fat-soluble vitamins as well as deficiency of vitamins B12 and iron. And then the systemic symptoms usually arising due to that increased intestinal permeability or leaky gut. So that would be anything really from joint pains, skin issues, psoriasis, headaches, fatigue, nausea, all sorts of systemic symptoms can arise. And one note with the clinical manifestations is that because we saw there are underlying diseases or dysfunctions that can predispose to SIBO, such as diabetes or hypothyroidism, it's important to obviously keep that into account as well, whether the symptoms are arising due to the underlying cause or due to the small intestinal bacterial overgrowth. So passing gas, kind of a lighthearted feature there, but cows are known to pass a lot of methane gas and actually I think contributes to a lot of global warming, but that's another story. But hydrogen and methane gases are not normally produced by human cells. They're only produced by the presence of bacteria. So hydrogen gases are typically associated with IBS D, that's diarrhea forms of IBS. And then methane gas, which is actually produced by archaea, not by bacteria. It's produced by these methanogens that use hydrogen gas and turn that into methane gas. But the methane producing IBS or methane producing SIBO tends to be more associated with constipation and tends to actually be a little bit more complicated or difficult to treat as well. So understanding the forms of gas that are produced, as well as identifying and characterizing them with a breath test, which we'll talk about, is going to be really important because the treatment will actually differ depending on the presence of these two gases as well as the levels of the gases. And there's actually a third gas that is produced that's not talked about as much. Some people are aware of it, some people aren't as aware of it, but hydrogen sulfide is a third gas that's produced by certain bacteria that reduce sulfate, and so they convert hydrogen gas into hydrogen sulfide. And the reason this one is not generally talked about as much is because the hydrogen sulfide at this point in time is not detected on the standard breath tests that can detect hydrogen and methane gas. So it's something that should not I would say should not be overlooked. So it should still be considered, but it's not talked about as much because at this point in time, we don't generally test for it. I think in the near future, there will be tests developed that include hydrogen sulfide gas, but at this point in time, we generally don't test for it. So what are some clues that someone might have an overgrowth of hydrogen sulfide producing bacteria? The main one is if they have a rotten egg smell to their flatulence or to their gas. They may also experience sensitivity to sulfur containing foods. And on the breath test, you may see a flat line of hydrogen and methane levels. So you don't really see a rise in hydrogen and methane levels, but the person still has symptoms typical of SIBO. So that might be a clue that someone is producing this hydrogen sulfide gas. So here's a list. This is not even a full list of conditions that have been associated with SIBO, either contributing to the underlying cause or SIBO contributing to these conditions. Each of these has some research showing that there's a link between them. So you can see this is a considerable amount of conditions that we likely see in clinical practice. And probably for a lot of them, we haven't considered SIBO as potentially contributing to these conditions or SIBO as a treatment for these conditions. So some of the main ones that have a high correlation with SIBO, rosacea is a big one, celiac disease as mentioned. So if you have celiac patients who are tested positive for celiac disease, go on to a gluten-free diet, but don't see the expected improvement in symptoms, SIBO would definitely be a consideration to take into account there. Reflux or gastroesophageal reflux disease, there's a high association with SIBO there. Obviously with IBS, but also with IBD, so Crohn's and ulcerative colitis could have underlying SIBO contributing to their dysfunction. Certain medications, interesting one, there's some research with Parkinson's disease having an association with SIBO, and restless leg syndrome, which can be a little bit difficult to treat or find the underlying cause. So SIBO can be a consideration. So with these associated conditions, I would say the best course of action is if someone has these symptoms and also has some digestive dysfunction, so IBS type of symptoms, you should at least have on your differential diagnosis SIBO as a consideration. So along with just having those basic clinical manifestations that we talked about, what are some clues that might make you think that a patient is suffering from SIBO? So this is important because you don't necessarily want to test every single person for SIBO. You don't want to be that thinking everything is caused by it, but you also don't want to be completely overlooking or missing it because it can be a really helpful diagnosis and treatment for some patients. So some clues to consider, as mentioned, if someone has that post-infectious IBS or if they have IBS type of symptoms that develop follow like food poisoning or a bout of gastroenteritis. As well, if someone has IBS symptoms that improve with antibiotic use. So using antibiotics for something else and they find their IBS symptoms improve, that can be a sign or a clue that SIBO might be a cause. A really big one is if someone has a worsening of their IBS symptoms when they have probiotics that contain prebiotics. So those are fructooligosaccharides or inulin, basically food for the bacteria, which normally should be helpful. But if you have small intestinal bacterial overgrowth, you're going to be feeding that overgrowth and making things worse. Or if people are having fiber intake, and that makes their symptoms worse as well. So this is really important aspect because some SIBO patients or IBS patients will have constipation as their main symptom. And we know for constipation, the basic treatment would be to increase water and increase fiber. So lots of people that might improve constipation, but for some people that will actually make their constipation worse. And that's because the fiber is going to be feeding the bacteria and producing more of the gases that are causing the SIBO in the first place. So that would be a big consideration there. Already mentioned celiac patients that don't improve on a gluten-free diet consider SIBO. And then also if you have IBS patients that have chronic low ferritin levels on lab testing, and even if you're supplementing with iron and their ferritin levels aren't going up and there's no other known cause for the low ferritin levels, SIBO can be a consideration because those bacteria can actually use up the iron and keep our body, our blood levels low. So now we've gone through some of the clues and the symptoms that are common with SIBO. So you've suspected that a patient has SIBO. What's the next step as far as diagnosis? So stool testing, it really doesn't have much value in the diagnosis of SIBO because it's really just giving a characteristic of the bacteria that's occurring in the large intestine, but not really indicative of what's happening in the small intestine. So not too helpful for SIBO unless there's maybe dysbiosis also occurring in the large intestine, which is possible. Another thing with stool testing is you may see fat in the stools or steatorrhea, which could be a sign of SIBO as well. I mentioned at the start sort of that gold standard of endoscopy or aspiration for the diagnosis of SIBO. So this still is used sometimes. However, it's very expensive and it's a highly invasive procedure. And it also has some downsides to it in that the endoscopy tube can only really reach the proximal portions of the small intestine. So you might miss distal small intestinal overgrowth, as well as prone to contamination. And lastly, at this point in time, we can't culture all the different types of bacteria. We can only culture a limited number of them. So endoscopy aspiration, not used as much, and it's mostly been replaced by the hydrogen methane breath test, which is, I would say, both clinically and in research, the most widely used test these days. And it detects the presence of hydrogen and methane gas in response to typically a lactulose solution. So with this breath test, there are a few different companies that provide this test, and sometimes they'll offer different substrates to provoke the test. Mostly it's either a lactulose solution or a glucose solution, and lactulose is preferred, and that's mainly because glucose is actually rapidly absorbed in the proximal duodenum, so you may not be able to detect the presence of distal SIBO, whereas with lactulose, it's not absorbed, so it will be able to travel through the length of the small intestine, which on average takes about 120 minutes, so it can give a better indication if there's distal SIBO present. So the way the breath test works is after taking a baseline sample, the patient would then take drink this lactulose solution and then take samples every 20 minutes. And certain labs do testing for 2 hours duration, whereas others do 3 hours duration. And it's actually preferable to do the 3-hour time frame because that's going to ensure you detect the full length of the small intestine as well as the large intestine, which might be missed with a 2-hour time frame. Oh, and just one more note. It's important to note that on this breath test, it's lactulose, not lactose, that's being used as the substrate for the testing. So breath tests can sometimes use lactose, and that would be testing for lactose intolerance. However, if you're doing the breath test for SIBO, you'd want to be using a lactulose solution, so slightly different there. There's lots of information you can find on this breath test, but usually there would be a recommended preparation phase before a patient undergoes the test, and it's usually about 24 to 48 hours. Before the test, the patient would go on a prep diet, which is a low fermentable foods diet. So as you can see, they'd only be eating certain foods like meat, and certain things that don't feed the bacteria, so that it gives you a good idea of a baseline level of gases. And then usually they would also recommend fasting for 12 hours before the test. So not eating anything after dinner time and then fasting overnight, doing the test the next morning. And then the test itself takes about 3 hours, and they wouldn't be eating anything during that time either. So it takes a little bit on the patient's part. And then what about vegetarian or vegan patients? These patients are going to be obviously even more restricted with their prep diet as well as with treatment diets, because they're not going to be eating any meat. And in the case of vegan patients, eggs or cheese, anything like that as well. So it can be difficult, but in my experience, most of the patients, by the time you're getting to testing for SIBO, they've probably had these IBS symptoms for a long time, have tried lots of different things. And if you have anything to offer that might be a potential positive diagnosis and lead to treatment, they're usually game for doing any of these strict prep diets. As far as actually doing the breath tests, the patients can get kits that they can take home and do themselves. There's a link here that goes through instructions for actually doing the test, so I won't go over that here. And then interpretation of the test. So this is also a little bit controversial or variable. Different labs might have different interpretations, as well as different practitioners. But in general, a positive test would be considered rise in high levels of 20 parts per million or greater within the first 120 minutes. And it's important, that distinction within the first 120 minutes, because that's when you're looking at fermentation from the small intestine, versus after 120 minutes, it might be showing the large intestine. So that's for hydrogen. For methane, also a little bit controversial, where a rise, Quintron, one of the test labs, says a rise in baseline of methane of 12 parts per million or greater would be a positive test. However, other research and other practitioners would recommend even a rise of 3 to 5 parts per million would be considered a positive test for methane. And then sometimes they'll sum the two of them for a positive test as well. So let's see a couple examples of positive tests. So this is a test that's performed through the Boucher Institute of Naturopathic Medicine. They have the Quintron test kit in their laboratory there. So this would be a patient where you can see initially at baseline they have low levels of both hydrogen and methane gas, and then within that first 120 minutes, you're seeing quite a rise, or a rise of greater than 20 parts per million of hydrogen gas. So that would be considered positive for hydrogen. And you can see they have a rise in methane gas of about 5. So this one would be one of those cases that's a bit more open to interpretation. I would say if you had a slight rise or elevation of methane and the patient had constipation type of IBS, you'd probably want to be considering that a positive result, but sometimes these are a little bit open to interpretation. Here's another example from a Quintron test. This is a typical, what they call a 2-spike or 2-peak test, where you have a peak in hydrogen levels within the first 120 minutes, indicating the presence of small intestinal bacterial overgrowth. And then you have a second peak after 120 minutes. And that's normal to see, because that just means the normal bacteria that are present in the large intestine are fermenting the lactulose solution. So anytime you see this big peak at the end of a test, that would be considered normal. And in this test, methane gas, let's see. Again, it's kind of right on the borderline of whether it would be considered a positive methane test or not. And then here's a third test. This one would be an example of a negative breath test. So here you don't have any significant elevation in gases within the first 120 minutes, and then you do see a rise in the last portion of the test. And again, that would just be indicating presence of normal large intestinal bacteria that are fermenting the lactulose solution. And I don't have an example of the hydrogen sulfide test, but I mentioned that one of the clues to hydrogen sulfide is if you had a flat line of both hydrogen and methane gases on the testing, but someone has SIBO symptoms. So if they had SIBO symptoms, they had a flat line on their testing, and they had, say, the rotten egg smelling flatulence, I would probably strongly consider that positive for hydrogen sulfide producing bacteria. And when we talk about the treatment for hydrogen sulfide bacteria would be similar to your treatment for a methane positive breath test. So what are the treatment steps? So you've suspected SIBO based on signs and symptoms. You've done a breath test that's come back positive. Now, what are your steps for treatment? So usually, and at the end of this webinar, I'll talk about my own protocol that I use, but most people would recommend an eradication phase of 2 to 4 weeks using either pharmaceutical or herbal antimicrobials. And some people would recommend before the eradication phase actually starting with some liver support for 1 to 2 weeks. And this can actually help prevent or reduce some of the die-off reaction symptoms that can be quite severe in the treatment of SIBO. So I would typically include this liver support prep phase. And then following the eradication phase, you would start a SIBO-specific diet as well as including prokinetic agents. So we'll talk about all of these steps here. So starting with the eradication phase. So what are the options that we have both pharmaceutically and herbally? As far as pharmaceutical options go, rifaximin is probably the most well-researched and most widely used antibiotic for SIBO. There's a few reasons for this. One, there's lots of research showing that it's effective at actually eradicating small intestinal bacterial overgrowth. Another good reason for using it is that it's not systemically absorbed, so people don't generally see side effects from it and don't develop a resistance to rifaximin. So it can be used for multiple courses, and it can be used on its own when there's a hydrogen positive breath test. So some of the cons or sort of downsides to using rifaximin. One is that if methane is positive on the breath test, rifaximin on its own is not effective at clearing methane, so it needs to be combined with another antibiotic, typically neomycin, or you can consider herbs as well, like garlic. And the other downsides to using rifaximin is that it's quite expensive and it's not too widely available, so it can be difficult to find in certain areas, but it certainly can be one consideration. But as naturopathic doctors, it's nice that we have in our toolkit all of these herbal options, herbal antimicrobials that, although they're less researched than the rifaximin, there is some, or at least one research study that's compared herbal antimicrobials to rifaximin and found them to be just as effective in the treatment of SIBO. And in my experience and other practitioners, I think they found similar effectiveness as well using herbs. However, the one difference is that with rifaximin, usually it's a course of 2 weeks, whereas with the herbs, usually we want to recommend them for 4 weeks. So it's a bit longer eradication period. And sometimes you may see a longer or more severe die-off reaction using herbs versus the pharmaceuticals. However, that can be mitigated a little bit by doing that liver support prep phase. So options for herbs. We know we have lots of different antimicrobial herbs in our toolkit, but what are some of the ones that have been researched? All of the berberine containing herbs, so coptis is one of the favorites of mine. So that's a herb in traditional Chinese medicine that has high levels of berberine, and it also can be used in TCM to address symptom picture of damp heat, which can have a lot of overlap with some of the symptoms that are seen in SIBO, so kind of just attacking things from a different angle. So that's one that I like to use, but the berberis species like Oregon grape or Hydrastis, golden seal, also is high in berberine. Garlic is commonly used as well, and I have a little star there beside garlic because garlic is really the only herb that's been shown to be effective at eradicating the methanogens, the methane producing archaea. So if there's a methane positive test, whether you're using rifaximin or the herbal antimicrobials, you'd want to include garlic in the treatment as well. And some other herbs that can be used, oregano, clove, neem, cinnamon. These ones have all been used both in research and in my practice and seem to be effective combinations. And usually using a combination of these herbs and considering that some bacteria might not be responsive to certain herbs but may react to other ones. So you may want to consider switching between different herbs. So doing 2 weeks of one group of herbs and the next 2 weeks doing a different combination or adding something in to make sure you're getting the full treatment that you're looking for. So the dietary phase, there's a reason that now I have this next. So I think when a lot of the early research was done on SIBO, the diet phase, starting with a SIBO diet or a specific carbohydrate diet or whatever it is, would usually be started following the positive diagnosis. So during that eradication phase, the diet phase would start as well to try and starve out the bacteria. However, there's been some recent research as well as my clinical experience and as well as others that shows that this eradication of SIBO is actually improved when there's still carbohydrates in the diet that are feeding the bacteria. So there's a saying that happy bacteria are easier to kill. And this is true basically for all bacteria. So if bacteria are not being fed and they're under stress or being under starvation, usually they'll wall off and they'll go into survival mode and can be much more difficult for the antibiotics to actually kill off. Whereas if the bacteria are multiplying and being well fed, usually it's the antibiotics will be more effective. So a clinical pearl would be not starting the specific carbohydrate diet or low FODMAP diet or whatever it is until after the eradication phase, so after the 2 to 4 weeks of eradication phase. So for diet options, there's no one size fits all diet for SIBO. Everyone's going to be slightly different in the diet that they respond to and do the best with. Some of the most common diets that are used are the specific carbohydrate diet, the GAPS diet, which is the gut and psychology diet, low FODMAP diet, or a combination of some of the above. And usually for the diet, you're looking at a minimum of about 3 months of doing the diet following the eradication phase, seeing how the patient reacts, and then maybe starting to introduce some more fermentable foods and seeing how the patient reacts. And then another diet option, which is probably not used as much, is an elemental diet. So this is basically a diet where a person would be taking just the basic elements of food, so fats, amino acids, things like that, with the idea that they would be quickly absorbed and not be actually feeding the bacteria. So some research shows that this can be an effective approach. However, the elemental diet can be quite expensive and usually poor compliance due to the taste of it. So it's not something that I usually would use in practice. So the specific carbohydrate diet, this is one of the more popular diets for SIBO, not developed specifically for SIBO, but can be helpful for it. Developed by Elaine Gottschall with her book, Breaking the Vicious Cycle. So her book and the website are good resources. And basically it's cutting out specific carbohydrates that would feed the bacteria. So trying to help starve the bacteria. So avoiding majority of grains, starches, and dairy. So that is one consideration that is used. There's also something called the SIBO diet that's been developed by some practitioners down at NCNM. So Alison Seebecker, who's a researcher in SIBO. And basically it goes through and gives there's a link to it here, but gives a chart for all the different food groups and list them according to foods that are less fermentable up to the foods that are more fermentable. And so especially earlier on, the patient would want to be sticking to the low fermentable or less fermentable types of foods, and then with time perhaps can start incorporating some of the other foods. So this SIBO diet really is a combination of the specific carbohydrate diet and the low FODMAP diet. So this is similar to what I would use in my practice. And along with diets, this is a really, really important consideration. So I'd call this a clinical pearl, is that one of the keys to preventing relapse or recurrence of SIBO is stimulating that migrating motor complex. So we saw that it can be part of the underlying cause that leads to the development of SIBO. So if you just do eradication and a diet and you're starving off the bacteria, but you aren't able to stimulate that migrating motor complex, there's high rates of relapse of SIBO. So some of the research estimates around 40 to 50% of people who have successful eradication, so they do breath testing, do pharmaceutical antibiotics, and then breath testing again and test negative for SIBO, but they don't use prokinetics, it's about a 40 to 50% chance that they will have a recurrence of SIBO. So this is really important to consider, and I think is really helpful in preventing the relapse of SIBO from occurring. So there's a few different options that can be used as prokinetics. Some pharmacological options that can be used, low dose erythromycin, low dose naltrexone, or prucalopride are three pharmacological options. The low dose erythromycin has a prokinetic effect but doesn't have an antibiotic effect at that dose. And with all of these prokinetics, you'd want to be using them, dosing them before bed, because that's when the migrating motor complex typically is most active. So aside from the pharmacological options, what are some natural options we could consider? So 5-HTP is a really nice option to consider, so dosing that before bed. And the mechanism there is that the low dose erythromycin actually acts on the serotonin, the 5-HT4 receptors, and that stimulates the migrating motor complex. So 5-HTP can act in a similar manner. D-limonene, there's limited research on it acting as a prokinetic, but in my experience, it can be a helpful addition, especially if there's reflux or GERD present in the patient. There are certain strains of probiotics that have been shown to have a stimulatory effect on the migrating motor complex. So the Bifidobacterium lactis and Lactobacillus rhamnosus, both of those have been shown to have that. Some clinicians or some practitioners will talk about iberogast, which is a European herbal formula that's been around for a long time for the treatment of just general gastrointestinal upset, and it may stimulate the migrating motor complex. And then a really important one to consider is with patients that they do space out their meals properly. So anytime we're eating, the migrating motor complex is not going to be active, whereas in between meals or overnight, that's when it is activated. So if a patient is snacking throughout the day, they're not going to have proper function of the migrating motor complex. So you want them to space their meals out by around 3 to 4 hours to allow that to occur, as well as not eating too late at night to allow the migrating motor complex to occur overnight. And then in addition to using a prokinetic, other tips or strategies for preventing relapse is to consider what is the underlying cause? How did that person develop the SIBO in the first place? So looking at those things, whether it is the migrating motor complex, whether they had low stomach acid, whether they had high stress levels, any of these things, if they're still present after the eradication and diet phase, if they're not dealt with, there's a high likelihood that they'll develop the SIBO again and then have to go through this whole process again. So some considerations could be using hydrochloric acid if hypochlorhydria is suspected as part of the underlying cause. I would say there's a caution though with this if the person tested positive for methane on their breath test, because the methanogens use hydrogen in order to produce the methane gas. So if you're using hydrochloric acid, that could be worsening or preventing proper treatment from occurring. And this could actually also be one of those clues where someone has some IBS type of symptoms, you try betaine HCl as a treatment, and they actually get worsening of their IBS symptoms. It's possible theoretically that the hydrogen could be feeding those methanogens and causing a worsening there. Other considerations are gut healing. So we saw there's a high degree of gastrointestinal hyperpermeability SIBO. So zinc carnazine, a number of different things that can be used for healing the gut. However, especially early on, some of our demulcent herbs that we might otherwise use for gut healing would be contraindicated because they can actually be fermentable and be feeding the bacteria. So maybe saving those for a later time. And then probiotics, a key here is making sure that the probiotics don't contain the prebiotics, the fructooligosaccharides or inulin or whatever it is, because those can be making things worse. Probiotics is a little bit controversial, although the research in my experience shows that for most people they can be beneficial during the treatment phase or the dietary phase. So I usually would incorporate probiotics and sometimes be starting slow and just making sure that they're FOS free. And usually I'll use a dairy free formula as well because it's possible that someone could react to the dairy in a probiotic. Not on this, but a couple of additional thoughts for preventing relapse. If you do acupuncture in your practice, acupuncture can be helpful for stimulating the migrating motor complex. You'd want to just be basically doing what you would normally do if someone had something like constipation, or stimulating flow that way, as well as reducing stress can be helpful for these patients. And then another important note is people properly actually chewing their food. So I think it's a common problem in North America in modern society is that people are often eating on the run and don't properly chew their food. So that old saying, nature will castigate those who don't masticate. Making sure people chew their food properly is going to help break down carbohydrates and lead to better absorption and less likelihood that they will be fermentable or leading to bacterial overgrowth. All right, so perfect timing. That's right about on an hour. So that will conclude the CE portion of this webinar. So that's the 1 hour CE portion. And so if you stick around, this next portion, I don't think will take us an hour, but I'll go through my own personal protocol that I use, as well as then we'll do our Q&A section. So let's, without further ado, let's get into this. All right, so my personal protocol that I use for SIBO, usually I would do the breath testing unless it seems to be fairly obvious that it's a SIBO case, and that's because knowing both the levels of gases as well as whether hydrogen or methane gases are present can be helpful in determining the treatment. And so usually I would do this prep phase to start with. So this liver support prep phase, I usually start 2 weeks before the eradication phase, and I use, so Vita is the sponsor of this webinar, and I use their product Hepicillin, which is a comprehensive liver support formula, 2 capsules per day. And this liver support can be really helpful in reducing the severity and the occurrence of die-off symptoms. So I would advise doing, if someone has the time to do, the liver support prep phase. And other things you can consider, things like the basics like lemon water first thing in the morning, or using castor oil packs, some of these other things that can be helpful for the liver. And then for the eradication phase, I typically will use the microcidin, which is an herbal antimicrobial formula from VitaAid. 1 capsule 3 times a day with food is the typical dose that I would use. A higher dose than that can be, it's pretty potent, so it can be too much to do that. And even the 1 capsule 3 times a day for some people might be a lot, and right off the bat might actually have more die-off reaction or higher die-off reaction. So sometimes I'll even start with a bit of a lower dose, like 1 capsule twice a day, and then up it after a week or two. I'll usually use probiotics, like a dairy-free formula without FOS, either starting with the eradication phase or sometimes following the eradication phase, starting with about 1 capsule per day before bed, because some research again has shown that it can be stimulating the migrating motor complex, as well as some research shows that it can actually improve outcomes in the treatment of SIBO. if someone doesn't tolerate it well, you can either consider starting with a lower dose, like half a capsule a day, and then slowly bringing that up, or switching to a different probiotic like the Saccharomyces boulardii, which is actually a beneficial yeast, not a bacteria, but it can be helpful for some of these patients as well. And usually during this eradication phase, I'll continue with the liver support because it's helping decrease the severity of the die-off symptoms. So following the eradication phase, sometimes I'll retest the breath test to see if the bacteria have been eradicated fully or not. Sometimes I'll just kind of go based on symptoms. It sort of depends on patient preference as well as their finances and things like that. So I'd say it's not a must to retest, but some people prefer to retest just to know. But I think sometimes you can just go ahead into the maintenance dietary prokinetic phase. So diet-wise, usually I'll use that a combination of that specific carbohydrate diet and a low FODMAP diet, but allowing for some individual variability, because the patients, they'll tell you if there's certain foods that they don't do well with, or if the diet is too restricted and maybe they're losing weight and you have to try and incorporate different things. So as mentioned, there's no real one size fits all approach for diet, and you really want to be keeping patient compliant. So these diets can be really restrictive, but hopefully the patient sees a significant improvement in their symptoms to the point that they'll continue with the diet, and then with time as they improve, you can start incorporating other foods. And as far as starting to incorporate carbohydrates or other fermentable foods, adding in digestive enzymes along with those meals can be helpful in breaking them down and reducing the chance that they're going to be contributing to fermentation or bacterial overgrowth. So a digestive enzyme like the Zymade, Carbofort with meals can be helpful. For stimulating the migrating motor complex, I typically use 5-HTP that'll dose after each meal, so spacing out their meals by 3 to 4 hours and having one capsule about an hour after meals, as well as one capsule before bed, I find can be effective at stimulating the migrating motor complex. D-limonene, usually reserving that one for patients that also have GERD, gastrointestinal or gastroesophageal reflux disease. So with this one, there's some good research on showing its effect for reflux, and I've seen it work for a number of patients in my practice as well. So doing 12 to 24 drops on an empty stomach, and making sure that the patient, if they're using this liquid drops, that they're actually dropping it into their mouth, because if they drop it into water, it can actually it can coat on the side of the cup or in the water and not actually, they might not be getting the full dose in. So the taste isn't great, but if they can just use it directly into the mouth and then wash it back with a little bit of water, that's the best way to use it. For gut healing or intestinal permeability support, I'll use an L-glutamine powder. This L-glutamine plus from Vita has L-glutamine and includes vitamins A, C, and E. So one teaspoon a day is the dose that I would use for this, and probably a majority of patients I'd use this one because they often in SIBO will have systemic symptoms, and that's usually indicating that there's some degree of leaky gut or intestinal hyperpermeability. And then continuing with the probiotics, the dairy-free and without FOS formula, and considering increasing the dose even with time. Okay, so that is my protocol. So now I'm going to go through and look at some of the questions that have been asked here, or if anyone has additional questions that they want to ask at this point in time. So let's see. I have a question that says, who is doing the antibody tests? So I mentioned those anti-CDTB and anti-vinculin antibodies. So it's, I believe it's Commonwealth Labs in the US, and they have a test called IBS check. So I'll see if I have my writing tool here, IBS check. So I believe if you Google IBS check, you'll find the information for those antibody tests. Okay, let's see what else. Hydrogen sulfide we mentioned. Dosages on the herbs. So I mentioned, hopefully I got to that there. Because the research is limited on the herbs, there's not too many clinical trials out there that actually talk about specific dosages for herbs. So what I use in practice is the dosages that I mentioned just now in my personal protocol, but some people will use differing dosages. Hopefully that answers that question. Let's see. The fast track diet. Someone asked about the fast track diet. I actually have not heard about this diet, so I can't really comment on that. But I would say that there are at this point a number of different diets that can be used for SIBO. To my knowledge, there's no research or clinical trials that have been done that are specifically looking at diets for SIBO or like a SCD or low FODMAP diet that's incorporating breath testing, eradication phase, and diet to see the results. So haven't really seen that yet. So a lot of the diet is just based on clinical experience as well as others' clinical experience, and it's open to variability, I would say. So not sure about the fast track diet, but if people are getting good results with it, it's probably similar on the same spectrum as a low fermentable diet, and it could be a valid consideration. Another question that's asking about ketogenic or ketosis diet in combination with part of the SIBO diet. Again, I don't have personal experience with that. It's not something that I've done in my practice, but it could be a consideration or consideration with certain patients. And as mentioned, there's no one size fits all approach to diet. Someone asked about biofilms. We didn't really touch on biofilms. It's something that it could be present in certain cases of SIBO. It's not something that's always indicated, but if it's a difficult case that's having a hard time with eradication, it's possible, theoretically possible, that it's due to biofilm formation. And so using some sort of like a nattokinase or something that can be breaking down the biofilms along with the antimicrobials or antibiotics could be a consideration. So in my experience, not always there, but in the more difficult to treat cases, biofilms definitely could be a consideration. There's a question regarding the breath test. Can meals be taken before or during the breath test? And that would be no is the answer to that. So the breath test, because you want to get a baseline response, they recommend fasting for at least 12 hours before the test is done. So say the person's doing the test at 9 in the morning, they want to be not eating or drinking anything other than water since 9 in the evening the night before. And then during the 3 hours of the actual test, they don't want to be eating or drinking anything either. So it's a bit of it's a bit of a process to do, but it's a valuable test, and I think most patients are okay with doing it. And if someone didn't follow the preparatory diet, it's a bit harder to interpret the results that you get. So sometimes if you had a high levels of gases at baseline and they didn't really follow the diet, you might consider that a positive test, but it's a little bit trickier to interpret the results if someone's not following the prep diet. Specific acupuncture points to stimulate the migrating motor complex. Not sure if there's specific points for the migrating motor complex itself. It would more just be in the general idea of sort of trying to stimulate bowel movements. So if someone had constipation, like the diamond approach or something like that, but there may be other points as well. But as far as specifically for the migrating motor complex, not sure if there is anything that's that specific for it. Just a side note on the migrating motor complex. Typically, it's not something that we test for or measure, but there are tests that can be done that can check for the electrical activity of the migrating motor complex. So we saw that one picture early on that showed those little electrical activity graphs, but it's not in clinical practice. It's not something that's typically done. A question, which lab do I use for the breath test? So I use the Quintron breath test from the Boucher Institute of Naturopathic Medicine in New Westminster. Um, so they offer this test. I'm in Vancouver, so it's an easy test for me to do. As far as Ontario, I'm not totally sure what the new regulations are. I know there's been lots of changes for the NDs in Ontario, so whether you're able to perform this test with your patients or not, I'm not totally sure on the regulations at this point. But that's the test that I use is the Quintron breath test from the Boucher Institute. There's a question specifically about the D-limonene, how many drops there are in a bottle. Not sure the exact number of drops, but it's a lot of drops if you're only doing 12 to 24 drops at a time. So it typically lasts for a long period of time. I usually am using it for someone who has uh, GERD or reflux. So uh, usually it lasts more than long enough for the patient to see a resolution. So the research that's been done on D-limonene for the use of GERD is usually doing 24 drops and doing it for only a period of 2 weeks, 2 to 4 weeks, and seeing an effect within that. So definitely one bottle has enough drops for to last a patient 2 weeks for sure. Someone asked, how does treatment differ with the hydrogen sulfide producing bacteria? So this one, again, it's something that I haven't come across as much, but I would treat this the same way as if you had a methane positive breath test. So with the methane positive breath test, you need to be adding something else in. So if it's rifaximin, you need to be adding in neomycin or some other antibiotic. Sometimes people will recommend metronidazole, or adding in garlic. Allicin from the garlic has been shown to be effective against the methanogens. So if you're doing the herbal treatment, you want to be including garlic as well. So if you're suspecting a hydrogen sulfide positive SIBO, I would treat it the same way that you would treat a methane positive. And I would also note that in general, methane positive or those that have more of a constipation dominant form of IBS or SIBO tend to be more difficult to treat. So it may involve more than one eradication phase. They might need multiple rounds. And I don't think I mentioned this when we were talking about the breath testing and the interpretation, but in general, each round of the eradication phase, you can expect to see a drop in about 25 to 30 or so parts per million of hydrogen gas. So if someone does a breath test and they have an elevation that gets to about 25, usually one round of eradication will be sufficient. But I think it's important to note to patients that one round of eradication does not always work. So it's not the same as using antibiotics for someone, say, has a respiratory infection or urinary tract infection where that completely clears up their symptoms after they take it. I think patients, if they're expecting that, may be disappointed because usually this eradication phase, they'll usually see a significant improvement in their symptoms, like a 75 to 80% improvement, but it's not the same as treating other things. It's usually a bit longer term and more involved, and they may have to brace themselves for the potential of having to do a second round of the eradication phase. So keep that in mind as well. Okay, let's see. Someone asked about the notes. Yes, so we'll be sending you this PowerPoint, all the slides. We'll send these to you afterwards so that you'll have them. Which lab do we use? I answered that one. Usual die-off symptoms can be variable, but people might see like extreme fatigue. They might notice even kind of like flu-like symptoms, malaise. They may see skin breakouts. It's quite variable and depends on the person, the actual severity of the die-off reactions. It doesn't occur in every patient, but for some people it can be pretty severe. So it's good to be upfront with the patient and let them know that it might be something that they might expect. Uh, Interesting question. So patients with an iron deficiency, would you continue to supplement with iron? This is a bit of a tricky question, but I would say that if someone has an iron deficiency and and you've tested and they've tested positive for SIBO, I would do the treatment for SIBO or at least do the eradication phase, and during that time not be supplementing with iron, and then you can continue supplementing iron following the eradication phase. Because the trouble with iron is that it's potentially feeding the bacteria. The bacteria can be using the iron themselves. So even supplementing with it, it might not be bringing up their normal iron stores or their ferritin levels anyways until you've actually cleared out that bacterial overgrowth. So I would recommend waiting until after the eradication phase to supplement with iron in a patient that's iron deficient. Question is thoughts on probiotic enemas for SIBO. That's a really good question. I'm not too familiar with probiotic enemas for SIBO. I haven't seen too much. I personally don't have clinical experience with doing them and haven't seen too much research on the use of them. So a bit tough to comment on the use of probiotic enemas for SIBO. A question is neomycin okay on its own with methanogens, or is the addition of rifaximin necessary? I would say yes, the rifaximin is also necessary. So usually you'd want to have a combination, and typically neomycin on its own or some other antibiotics don't seem to be effective on their own. I mean, it's possible in some cases, but usually um, if you have methane positive, it can be difficult to eradicate. So you want to be kind of using a few different tools or going at it a few different ways to really try and clear out that bacteria, or I should say archaea in the case of the methanogens. Uh, yeah, breath, answered that about the breath tests. Uh, this is a good question. So, do you have a resource for vegetarian or vegan patients, especially for the test prep? I don't really have, there's lots of resources you can find as far as SIBO diet goes online, but things become even more difficult if you have a vegetarian or vegan diet because many of the diets are going to be almost similar to a paleo type diet where they're very heavy in the meat department. And if you don't, if you're not able to eat that, the diet becomes even more restricted. I just had a patient that we did the breath tests on who is a vegan, and so for the prep phase, we limited the prep phase to 12 hours. So that the day before the breath test, we just had her. She was just eating white rice and oil and salt and pepper, so pretty boring. I know, but she was okay with doing it. We just did it for the one day, and then she did the overnight fast, and the results for the test, the baseline levels were basically at zero. So it seemed to be effective in her case, but certainly with vegetarian and vegan patients for the test prep as well as the treatment diet phase, it becomes a little bit more difficult to treat for sure. Huh, that's a really interesting question. So someone asked, do you think that sine wave constitutional hydrotherapy would be helpful for the migrating motor complex? Again, not something that I've used personally or seen any research on, but it's one of those things that with SIBO, you can try, different things are going to work for different people. And if, constitutional hydrotherapy might have additional benefits anyways, whether or not it's actually stimulating the migrating motor complex, the things that I presented are things that either I have personal experience with or there's a good degree of research on them. So can't really comment on this, but it would be an interesting thing to try for sure. Mentioned the lab already, so Quintron from the Boucher Institute. Um, with lab testing as well. So we just talked about the breath test because that's specific to SIBO, but often patients, this presentation was as if you have your ideal SIBO patient where that's all they have is SIBO, and you do the testing and you do the treatment, but often they're going to present with other conditions or other things might be going on. So it may be helpful to do some blood work to check for B12 or other levels, food allergy or food sensitivity testing, comprehensive digestive stool analysis to see if there's something going on with the large intestine. There's a number of other tests that could be indicated that might show you that there's something other than SIBO going on with this patient, and might give you some other tips for the actual treatment. Yeah, okay. So someone asked about with the breath testing, they have on the side, you might have noticed something called the CO2 check. So that's something offered by Quintron in some of the lab tests. And basically, it's just ensuring that you have an adequate breath sample. And occasionally, they'll show if they didn't have an adequate breath sample, there won't be the CO2 present. And so that sample would be invalid. And so it would actually say that, and it wouldn't give you a clear indication of hydrogen or methane levels. So the CO2 check isn't telling you anything about the SIBO or the hydrogen or methane. It's just telling you that you have a proper breath sample. Good question. So if someone has to do more than one round of the eradication, how soon do you start it? So this is a little bit, there's no one clear answer to this because some people, they might relapse right away. Some people might be relapsing after a period of time. So that's usually when you would either retest or retreat, is once the person's symptoms come back. And so if you do the eradication phase and someone, their symptoms come back very quickly, that could be indicating that there's some sort of possibly a mechanical obstruction or adhesion or something else going on that's sort of preventing the treatment from being effective. Whereas if they relapse, 6 weeks or 6 months or whatever it is down the road, it might be that they either didn't stay on the strict enough diet for long enough, they weren't using the prokinetics, they weren't compliant with the treatments, or some other underlying cause hadn't been addressed. So as far as how soon do you retreat depends on when the symptoms recur. And you can retreat either with the antimicrobials, the herbals, or you can try different combinations, or with the rifaximin, because it doesn't develop antibiotic resistance, it can be used for multiple courses. However, with that, the research that's been done comparing a 2-week course of rifaximin to a 12-week course of rifaximin doesn't show that the 12-week course or the long-term course is really any more effective than doing a short course of rifaximin. So main reasons for treatment failure. So one of those would be not addressing that migrating motor complex or not addressing other potential underlying causes. So if someone, say example, had a low stomach acid levels and you didn't address that, if they weren't compliant with their diet, I mean, there's a number of different reasons for treatment failure, but I'd say a big one is the migrating motor complex, because previous studies that had been done on SIBO and eradication with rifaximin show relapse rates in the range of 40% of people, but typically in those studies they don't use any sort of prokinetic or additional treatments or therapies. So in my experience, and I believe in other people's experience, when they do use these additional therapies, the relapse rates tend to be quite a bit lower than the 40% range. Okay, and I believe that's it for the questions. So I'll just give you an idea of a couple of the products that I use. So the microcidin, this is what I found to be the best herbal antimicrobial product. It has a combination of different herbs in it. It contains the coptis, which is high in berberine, as well as in Chinese medicine, effective for treating damp heat. It has a clove extract, which is shown to have a synergistic effect with Coptis. It has garlic and oregano in it as well. So it's a really nice combination formula that I've found to be quite potent and very effective for the eradication phase in SIBO. And then for probiotics, the Vitaid Supreme PV30 Plus is a certified dairy-free formula and can be formatted with or without FOS. So when you're talking about SIBO, I recommend the without FOS formula. And it's a high dose. At the time of manufacturing, it has 55 billion bacteria per capsule, and so guaranteed to have 30 billion and multiple strains. So you're containing some of those strains that can be helpful for stimulating the migrating motor complex. And all of the strains have been tested to be acid and bile resistant and shown to anchor the human gut lining. So really important anytime that you're considering probiotics. The D-limonene, there's a liquid formula called limonene. And this, again, I would use particularly in SIBO patients if they have gastrointestinal reflux disease or acid reflux, or even in non-SIBO patients if they have reflux. This is usually my go-to product to use. So using 12 to 24 drops once a day for about 2 weeks shows significant improvement in clinical trials of acid reflux, and I've seen it to be really effective in my own personal experience, as well as helping if you're trying to wean patients off proton pump inhibitors, which can be difficult to do, especially if they've been on them long term. This can be really helpful in helping wean off of PPIs. The hepicillin, so this is the formula I would use for that liver prep phase of about 2 weeks. So it's got milk thistle, dandelion, artichoke, alpha lipoic acid. So a really nice all-around formula to support the hepatic cells themselves, as well as phase 1 and phase 2 liver detoxification, which is during the die-off reaction, the bacteria are releasing toxins that need to be metabolized through the liver. So if you have an overburdened, or you could say sluggish liver, then you're more likely to have die-off reactions. Whereas if you have properly functioning liver detoxification, you would be less likely to have the die-off reactions. And so a note from this webinar, we have a promotion going, or Vitaid has a promotion going on where the products that I've talked about in this webinar, the microcidin, the 5-HTP, the probiotics, the D-limonene, and the hepicillin will all be 10% off until the end of March. So if you have any SIBO patients and you would like to try out this protocol that I recommend, this would be a good time to give these products a try. And I'd like to give a special thank you to Dr. Omale at the Boucher Naturopathic Clinic. She's been a big help in resources and putting together this webinar. And you should all be able to download, or we can send you the link to download this webinar, so you'll have the resources. And I'll also be doing a SIBO webinar part 2 in mid-June. And so in that webinar, we'll be covering more of what to do in the stubborn cases. So you've gone through this protocol and it's not working. So what do you do then? And I'll also talk a bit more about differential diagnosis. So often symptoms of SIBO can be confused with a candida overgrowth. So how do you differentiate between those two, and how might your treatments differ? So that's something that can come up often. And I'll also be presenting sort of an updated treatment protocol for SIBO based on the latest research. So look forward to that in your emails when we set the exact date, but it will be sometime in mid-June. So if there are not any additional questions, anyone else have any last minute questions before we finish up here? Someone asked if you can buy these products in the US. Yes, we do ship to the US as well, so you can buy them both in Canada and the US. So you can contact us, contact VitaAid through the website or respond to the link that you received. All right. Thank you very much, everyone, for attending. I hope you enjoyed it and found it informative. I was happy to present this information because I think it's a really important topic. And if you're interested in any more of the VitaAid products or information, you can visit their website, www.vitaaid.com. Again, my name is Tomah Phillips. Have a good rest of your day. Thank you.